So without further ado, it's my absolute pleasure to welcome Delaney Fisher to talk about focus ultrasound. Delaney Fisher, PhD, recently graduated from the University of Virginia with her doctoral degree in biomedical engineering. Under the mentorship of Dr. Richard Price, her dissertation work centered on pioneering focus ultrasound as a new, non-invasive treatment option for cerebral cavernous malformation. Dr. Fisher is now at Duke University, where she is researching targeted gene therapy for cavernomas with Doctors Arvind Bhaskar and Doug Marchuk. So, Delaney, thank you so much for joining. I'm now going to hand over to you to screen share. We're really looking forward to hearing your presentation. And then when you're done, I'll come back on and we'll go through questions.
Right, great. Thank you so much for that introduction, Helen. I'm really excited to be here today and to be able to talk with everyone about my dissertation work. So as Helen mentioned, I spent many years working on focus ultrasound and trying to create a treatment option for cerebral cavernous malformations with this approach. So today we'll be talking about what focus ultrasound is, how it works, and how it's used in other disorders. And we'll also then launch into how we can specifically use focus ultrasound to treat cavernomas. And we'll be talking about a lot of the work that we did in Dr. Price's lab at the University of Virginia. So with that, we'll start on our background of focus ultrasound. So focus ultrasound is a rapidly evolving, non-invasive therapeutic technology that has the potential to transform the treatment of many different medical disorders. And it does this using ultrasound energy that allows it to target deep within the body without any incisions or radiation. And this therapy combines the use of two different technologies. So one is focus ultrasound itself, which provides the sound energy to treat the tissue deep within the body precisely and non-invasively. And then the second is usually some form of imaging that allows us to see the target tissue. So when we talk about the brain, that's typically going to be magnetic resonance imaging or MRI that allows us to identify the target tissue and confirm the effectiveness of our treatment. And I think it's helpful to kind of think about focus ultrasound by framing it against what diagnostic ultrasound is, which most of us are probably familiar as a way to monitor things within the body, typically pregnancies. And with focus ultrasound, we're essentially just taking these same ultrasound waves, but now concentrating them into a very small volume where we can then produce a wide range of mechanical and thermal effects within the target tissue. And I like to use this analogy of comparing it to holding up a magnifying glass up against the sun, where we can then concentrate sun rays and actually cause enough heat from this concentrated sun energy to heat up the leaf. So this is a similar analogy where instead of sun rays, we're now looking at sound waves where we can concentrate them into a really small volume that can cause thermal effects, but also mechanical effects in the tissue. And so I just want to remind everyone that sound waves are really just pressure waves. And that means that over the course of a sound wave, we're really oscillating between this high pressure state and low pressure state over time. And we can manipulate these sound waves in many different ways, such as increasing the pressure that's applied or decreasing the pressure that's applied. And we can also do this as a continuous sound wave, or we can actually pause the sound wave over time where we have these short pulses of sound wave. And so all these manipulations of the focus ultrasound can result in many different types of mechanical and thermal effects within the body that produces various biological effects within that tissue. And the slide is a little bit busy, but I basically just want to highlight the many different ways that we can produce different biological effects. So we can cause non-thermal effects, we can cause thermal effects, and something in between, typically mechanical effects. And all of these can produce a range of different treatments within the body. So that can include tissue destruction in the case of tumors, immune modulation. It can cause drug delivery, vascular dilation, and neuromodulation, to just name a few. But you can see that there's a lot of different things that we can produce as a result of manipulating these sound waves with focus ultrasound. And all of these biological effects that we can produce with focused ultrasound is what makes it so versatile as a treatment for many different diseases. So looking at this diagram, we can see that focused ultrasound is used to treat many different diseases, ranging from women's health issues to abdominal issues to neurological issues, just to name a few. And there's so many more. And with all of these different diseases that focused ultrasound is being explored for, the development of focused ultrasound treatment ranges from these early preclinical stages where everything's still happening in the lab, and then all the way to insurance approval and regulatory approval and reimbursement. And we can see that many of these diseases have some range between, and I'm just showing a couple or a small subsection here. And there's actually over 150 different disorders that are being examined or used using focused ultrasound to treat these diseases as of 2021 at one of these stages within the preclinical to a clinical approval process. And so far, patients have undergone over 565,000 treatments so far with focused ultrasound. Many of those have focused on the treatment of different tumors, but there's also been a rise in patients with neurological diseases that are being treated as well. And those can include things like essential tremor, Parkinson's disease, and Alzheimer's disease for the most part right now. And so with this background of what focused ultrasound is, we can now launch into how we're actually using this to treat cavernomas. And in this talk, I'll be talking about two different ways. So the first being temporary and reversible blood-brain barrier opening that we can induce with focused ultrasound, and then using this approach to actually enhance drug delivery, hopefully to the cavernoma. And so, as I'm sure everyone in this audience is more than aware, the current standard of care for CCM is surgical resection of the cavernoma. Of course, though, more treatment options would be very preferable, especially because surgery can always present some risk to patients. And it also leaves many lesions not in great places to be operable. So focused ultrasound is great because it can actually target these specific cavernomas deep within these deep-seated lesions in the brain. And while the motivation for treatment is high, we're still at the early development stage for cavernoma treatment with focused ultrasound. Specifically, we're still in this preclinical stage, meaning that the research is still happening at the laboratory setting and patients have not yet been treated yet. And then at the University of Virginia, we've been exploring non-thermal biological effects produced by focused ultrasound for CCM. Specifically, this blood-brain barrier opening approach, where we can use that alone to see if we can get therapeutic effects. And then we can pair that with drug delivery to hopefully enhance the ability of a drug to get into the cavernoma. And so before we talk about blood-brain barrier opening, I think it's important for us to make sure we're all on the same page about what the blood-brain barrier is. So within the brain, we have lots of blood vessels, and here we're going to zoom in on one of them. And these blood vessels within the brain are actually pretty unique compared to blood vessels within the rest of the body. And that's because these cells that make up the blood vessel wall in the brain prevent most things in the bloodstream from actually crossing into the brain tissue. It only allows really small molecules and things that it needs to survive, like oxygen and sugar. But this can be problematic when we need to treat a brain disorder, since we might actually have this great drug, but we actually can't get it into the brain tissue to be effective. So in these cases, it would be really helpful if we could just temporarily open up this blood-brain barrier and allow that drug to cross into the brain tissue to be effective. And so now let's talk about how we can actually do this blood-brain barrier opening with focused ultrasound. So as a reminder, the sound waves are really just pressure waves. And with focused ultrasound to do this approach, we use these sound waves in combination with something called microbubbles. And so these microbubbles are really just small bubbles that are filled with gas. And they were originally used as ultrasound contrast agents. So at high pressure, the gas inside these microbubbles will compress, causing the microbubbles to shrink in size as well. But then at low pressure, the gas inside will expand, which also causes the microbubble to expand. So over time, these microbubbles are going to oscillate between this expanded and compressed state over time. And then this is going to happen within a blood vessel. And so to see how this really comes together within the body, we're going to zoom in here on one blood vessel within the brain, and we'll start by injecting our microbubbles IV into the bloodstream. And then we can apply our focused ultrasound specifically to where we want to target. So in this case, that will be the cavernoma. And I really just want to highlight that the focus part of ultrasound is that we can really apply these sound waves just to a specific region of the brain. This won't necessarily cover the whole brain. We're actually just having those sound waves converge in a very small 1 millimeter size precision spot within the brain. So we can really finely target places within the brain that we want to treat. So now these microbubbles will start to oscillate wherever they encounter the ultrasound waves. And this oscillation of the microbubbles will push and pull on the blood vessel wall. And that causes a temporary disruption of the blood-brain barrier. So now if we were to inject a therapeutic agent into the bloodstream, we can actually see that cross this blood-brain barrier and accumulate specifically where we targeted with focused ultrasound in the brain. And then I really just want to emphasize that this is a temporary effect. So we would expect complete closure of the blood-brain barrier by 24 hours after this treatment. And so why would we want to use this approach for treating cavernomas? So hopefully you've seen through the talks today and from the Alliance that there are lots of drugs that are really being explored for treating cavernomas. But this approach can be helpful in basically increasing the concentration of these drugs inside of the cavernoma, essentially enhancing the amount of the drug that gets into the cavernoma rather than going to the rest of the body. But it can also help us unlock the delivery of larger molecules like antibodies and gene therapies, which really aren't being explored as much due to their larger size, which doesn't let them cross into the blood-brain barrier as efficiently as it does smaller molecules. And so this table is really highlighting many of the drugs that are being explored currently for the treatment of cavernomas. And I think it's important to note that the large majority of these drugs are small molecules. So this really highlights again that the exciting potential of focused ultrasound is that it could really unlock this ability to have whole new classes of drugs for the treatment of cavernomas. And this temporary opening of the blood-brain barrier would enable new candidate drugs to expand beyond just these small molecules and make those larger drug options more feasible for the treatment of CCM. And then beyond just drug delivery, focused ultrasound can also induce other effects for brain disorders. So rather than just opening the barrier to help get things from inside the blood vessel into the brain, it can also help us to clear things out of the brain, like toxins that build up there, and get those out. Others have also shown that after focused ultrasound, you can get the stimulation of new neurons or neurogenesis. And then, of course, we're applying pretty strong mechanical cues to this blood vessel wall during the process, which could also change cell signaling in these cells that are affected with CCM, which could be also beneficial. And so these secondary effects for focused ultrasound have been especially well studied in the case of Alzheimer's disease, where other research groups have demonstrated that focused ultrasound blood-brain barrier opening can result in a reduction of amyloid beta, which is what builds up to cause those plaques. It can also cause a restoration of memory, new neural activation, and the formation of new neurons in animal models of Alzheimer's disease that are treated with focused ultrasound. And then to just provide a little more clinical perspective here, so far patients have undergone over 12,000 treatments with focused ultrasound for the brain as of last year. So many of these have used the thermal or the heating effect of focused ultrasound to treat movement disorders or brain tumors. But there's also been a rise in people that are getting the blood-brain barrier opening approach now as well. And there's actually currently 25 clinical trials that are active or completed that have used this focused ultrasound blood-brain barrier opening approach, with a large majority going to brain tumors and then a smaller subset for Parkinson's disease and Alzheimer's disease. Okay, so with that background in mind, we're now going to launch into some of the data that I have where we've used focused ultrasound to treat CCMs in mouse models. So we'll first launch into this part where we're just looking at the effect of blood-brain barrier opening alone. So in this first study, we asked if focused ultrasound could effectively open the blood-brain barrier within the CCM microenvironment. So this has never been done before for CCM prior to our study, so we wanted to make sure that this would, work well. And then we wanted to see if it was actually safe, especially considering that CCMs are prone to bleeding. We want to make sure that this isn't going to make those worse. And then finally, we wanted to see if focused ultrasound blood-brain barrier opening, in the absence of any therapeutic drug delivery, was therapeutic for CCMs, so by itself. So in answering this first question, we started by acquiring the MRIs of a cohort of CCM mice, and then we selected cavernomas to sonicate from these images. Then we injected our mice with an MRI contrast agent known as gadolinium, and we applied focus ultrasound with a range of different peak negative pressures. And again, these pressures are basically just the amplitude of the sound wave. So a higher pressure would basically indicate that we have a higher amplitude, and therefore we should expect those microbubbles to grow bigger. And therefore we might expect a bigger degree of blood-brain barrier opening as opposed to a smaller pressure or smaller amplitude of that sound wave. And then we confirmed that the blood-brain barrier opening approach was working by evaluating the contrast enhancement in a post-MRI. So basically this MRI contrast agent that we're injecting, if it can actually get into the brain tissue, which normally it can't because of the blood-brain barrier, then we should get this white signal produced on the MRI, which will let us confirm that we did indeed get blood-brain barrier opening. And so to walk you through the results of our initial experiments, we have here in the top row our baseline MRI images that we use to select our cavernomas to target. Those are denoted by the different arrows. And then in the middle row, we have our pre-focus ultrasound images taken on the day of focus ultrasound treatment. And so you can see a little bit of white signal around some of these CCMs from our MRI contrast agent. And that's just basically telling us the baseline leakiness of these cavernomas. And then finally, in the last row, we have our post-focus ultrasound images where we can now visualize if we were successful with our blood-brain barrier opening approach. And we can see that there is this increase in the white signal or the MRI contrast agent getting into these cavernomas, indicating that we did indeed open the blood-brain barrier with this approach. And we actually see that for the pressures that are greater than 0.2 megapascals, we do get an increase of this contrast agent and have successful blood-brain barrier opening compared to before focus ultrasound. And so next, we investigated if focus ultrasound blood-brain barrier opening is safe for these hemorrhage-prone CCMs. So in these studies, we use one form of MRI called a T2 spin echo to measure the volume changes. And then we use susceptibility-weighted imaging to identify bleeding or hemorrhage following this approach, so one day after. And we did this before and after focus ultrasound to assess, again, the volume and the bleeding. So we found that there were no increases in the cavernoma size on our T2 weighted or our susceptibility weighted imaging one day after focus ultrasound for any of the pressures that we applied here. And we have this quantified here below as the absolute volume changes between the lesions before and after, or the change in volume here on the right. So ultimately, this indicates that focus ultrasound blood-brain barrier opening is not inducing any acute growth or bleeding of CCMs. And then finally, we investigated if there were any therapeutic effects of blood-brain barrier opening for CCM in itself. So in these studies, we divided mice into multiple treatment arms where they either received a single focus ultrasound treatment or a repeat treatment staged 3 days apart. And we further tested either the effect of what's known as a fixed peak negative pressure, which is what I've been showing you up to this point, where basically we're just applying the same pressure for the whole time of this sonication, which is 2 minutes long. But we also need to test what's known as passive cavitation detection modulated peak negative pressure, or PCD modulated peak negative pressure. And with this approach, we're basically taking the activity of the microbubbles during the sonication time to regulate the applied peak negative pressure. So basically, if we have more microbubble activity, we can damp that down by reducing the pressure that's applied. And this PCD modulated approach is important for us to include because this is the approach that's actually used in the clinic for BBB opening in patients to just further ensure the safety of this treatment. And so we first looked at CCM growth in sonicated versus non-sonicated contralateral lesions in the same mice. And based off of a previous study where we characterized our mouse model, we saw that we would expect for lesions to naturally be growing in size and number during this time period. So basically, we can expect our non-sonicated lesions to grow, but we'll see if the sonicated lesions are changed during this 1 month time period. And so looking first at our single focus ultrasound treatment arm and the fixed peak negative pressure, we have here on the left our representative MRIs. In the top row are our non-sonicated lesions, and in the bottom row is our sonicated lesions with 0.4 or 0.5 Pascal pressure. And looking here at the quantification of this data, we see our non-sonicated lesions are growing during this 1 month period as we would expect, but our sonicated lesions do not grow, indicating that we're actually stabilizing the size of these lesions after sonication. When we look at the repeat treatment arm with fixed peak negative pressure, we again see that our non-sonicated lesions grow in size as expected, but the non-sonicated are stable after focus ultrasound treatment. We also look at the different pressures that we're applying here, but we really don't notice a difference with any of these pressures. One doesn't seem to be performing better than the other. And then looking at the repeat focus ultrasound treatment arm with our PCD modulated approach, we again find that our sonicated lesions are stable compared to the non-sonicated lesions 1 month after growth. So this is indicating to us that both the single and the repeat focus ultrasound approach, as well as fixed peak negative pressure and PCD modulated approach, can all be useful for controlling the growth of sonicated lesions, which is really exciting and was not necessarily expected, actually. And so next, we were curious if focus ultrasound blood-brain barrier opening also impacted the formation of new CCMs. So this is like a familial model of CCM, so we would expect these lesions to be growing in number as well over time. So to examine this, we first started by laying over our focal zone, or the spot that we treated with focus ultrasound, in the image before focus ultrasound, as well as the image 1 month after focus ultrasound. And then we mirrored this column onto the other hemisphere, which was not treated with focus ultrasound. And then we could compare the number of lesions in this treated zone and the non-treated zone before and after focus ultrasound to basically quantify the number of lesions that formed during this 1 month period with each condition. And so here on the left, we have our MRI images. In the top row, we have the images that were taken on the day of focus ultrasound treatment, where the white signal is denoting where we treated with focus ultrasound. And then in the bottom 2 rows, we have the before and the 1 month later image, where we can visualize the number of lesions that formed during this time period in the FUS or the non-FUS treated side. And so we see with the single focus ultrasound treatment group that we do not induce new lesion formation with focus ultrasound, which is really important. We're not making things worse. When in fact, we actually see this trend towards a mild reduction in lesion formation. When we look at the fixed peak negative pressure and repeat focus ultrasound group, we actually see that there is a statistically significant difference so that we are actually reducing the number of lesions that are forming in the focus ultrasound treated zone compared to the non-focus ultrasound treated zone. When we look at the PCD modulated approach, we again see that there's no new lesion formation, but there's a mild decrease in lesion formation with blood-brain barrier opening. So ultimately, this is indicating that not only does focus ultrasound have this protective role of controlling the growth of sonicated lesions in the absence of any therapeutic delivery, but it also has this potential to have a preventative role for CCM too. So where with the right dosing and timing of focus ultrasound, we actually might be able to prevent new lesions from forming. And this would be really beneficial for patients, especially that have the familial form of CCM that are, of course, regularly forming new lesions as they age. And this approach also has this ability to still seamlessly integrate with therapeutic delivery to even further enhance its potential for CCM treatment, which is what I'll be talking about in the next section. But to just wrap up this section before we move on, so in conclusion, we basically demonstrated the first application of focus ultrasound for CCM. We find that focus ultrasound can open the blood-brain barrier and enhance gadolinium accumulation to the CCM microenvironment. We find that focus ultrasound does not induce any acute growth or bleeding of these hemorrhage-prone CCMs. We also find that blood-brain barrier opening controls the growth of sonicated cavernomas, and that the repeat blood-brain barrier opening with the fixed peak negative pressures can reduce the formation of new lesions. And so now we'll move into the second part where we actually pair this approach with drug delivery to see if we can enhance the ability of drugs to get into the cavernoma. And so to do this, we leverage what's known as T1 mapping, which is basically just a fancy form of MRI that allows us to measure the permeability of CCMs. And so in this talk, this part of the talk, we aren't actually delivering therapeutic drugs, but rather we're injecting drugs that we know the size of, and they're actually visible on MRI. So these are really just model drugs that let us know or track them with MRI, and will basically give us a reference for how much of a drug of this same size we should expect to get into the CCM. And so specifically, we're using a model drug called Multi-Hance, which is representative of small molecules. It's about 1 nanometer in diameter. And then we're using this slightly larger drug known as Gadospin, or model drug known as Gadospin, that's a little bit larger. It's about 5 nanometers in diameter, and it's more representative of small biologics like proteins. And so first, we wanted to see if focused ultrasound blood-brain barrier opening could increase the rate of small molecule delivery into the CCMs. So to do this, we start by acquiring our MRI before any contrast agent is injected or model drugs. That gives us just a reference. And then finally, we inject this MRI, we acquire the MRI following the injection of our model drug. Then we apply focused ultrasound to just one hemisphere, leaving the other hemisphere untreated. And again, we acquire MRI following focused ultrasound. So now we can compare the delivery of this model drug before and after focused ultrasound treatment. So we have the focused ultrasound treated side, lesions that were not treated at all during this time course. And we can also look inside of the lesion, so in the intralesional space or the core of the CCM. But we can also look at the area immediately surrounding the CCM, known as the perilesional space, which is therapeutically a good target because this is basically where the lesion will be expanding into next. So it's therapeutically relevant to see if we can get drug there. And so here we have the results from this experiment for the Multi-Hance or small molecule data. So on the left is this reference MRI image, and on the right is the concentration map, where we basically are able to quantify the concentration of our contrast agent, where more drug would be yellow and less drug would be represented by blue. And so quantifying, let me explain this. So in the top, we have our non-focused ultrasound treated before or 10 minutes after post-injection. And then in the bottom, we have after 30 minutes following the Multi-Hance injection, with the left side being non-focused ultrasound treated and the right side being focused ultrasound treated. And we can visualize more yellow or more drug in this focused ultrasound treated side. And so we can quantify this concentration map for inside of the lesion, the lesion core. And we see that we are increasing the slope or the rate of the delivery of Multi-Hance following focused ultrasound treatment. Those treated are in the color blue, whereas those that are not treated continue to have this pretty similar slope over the same time period. And in fact, if we look at the slope of this portion of the graph compared to this portion of the graph for our focused ultrasound treated or not focused ultrasound treated, we see that the slope increases threefold following focused ultrasound for those that are treated with focused ultrasound, whereas those that are not treated actually have a slight decrease in the slope during this later time period compared to the earlier period. Looking at the perilesional side, we also see this trend where we have an increase in the rate of Multi-Hance delivery with focused ultrasound. And now this is a fivefold increase in the perilesional space or the lesion, the area right around the lesion. So this data indicates that focused ultrasound increases the delivery rate for small molecules. But next we wanted to see how much more focused ultrasound blood-brain barrier opening would enhance the total amount of the model drug that's making it into the CCM, which is more therapeutically relevant. So it's basically letting us know how much more drug could we get into the CCM in total compared to if we did not use focused ultrasound. So to do this study, we started by first injecting either model drug, Multi-Hance or Gadospin, and we acquired MRI on day 1. And this basically gives us the baseline expectation for how much of that drug would get into the cavernoma without focused ultrasound. Then we came back the next day and we applied focused ultrasound and acquired our MRI again. And now we have the amount of the drug that gets in with focused ultrasound. So we can compare these two in the same mice and in the same exact lesions, which is really powerful. And so looking first at the Multi-Hance data or the small molecule data, we here have our MRI images before focused ultrasound treatment and our concentration maps below. And then we have with focused ultrasound treatment on the next day. Again, we're just treating one hemisphere, so you can see that there's an increase in this yellow or the amount of the drug that's getting in with focused ultrasound on this right side. And so if we quantify this, we can see that multi-enhanced concentration inside of the lesions is increasing about 2.5-fold 20 minutes after focused ultrasound treatment. And we find that if we actually integrate this data, which basically tells us the exposure of this cavernoma to that model drug, we can also see that we're increasing that exposure with focused ultrasound significantly compared to without. In the perilesional space, we again see a similar trend. So we see that there's a 3-fold increase now in the number of, or the concentration of multi-enhanced within that cavernomas that are treated with focused ultrasound, and the exposure is increased as well. And so now if we look at the slightly larger model drug, Gadospin, which is more representative of biologics, we again see that we are increasing the amount of this biologic that is getting into the cavernoma. And in this case, it's much higher. It's around 22-fold. Looking at the space around the lesion, we again see that we're increasing the amount of the Gadospin that is getting into the space just around the lesion by about 4-fold. And so again, this study is helpful because it's letting us predict how much more of a biologic drug or small molecule would be delivered to CCMs with focused ultrasound. And in this case, with the biologic drug, we can see that we're essentially getting in almost nothing almost no drug of this size is expected to really get into the cavernoma. But we can actually increase that a lot by using focused ultrasound and letting that drug get in. So again, this really highlights the potential of focused ultrasound to really enable new classes of drugs to be used for CCM beyond just those small molecules. And so to wrap up this part, so focused ultrasound, we see enhances the delivery rate of small molecules within the CCM, both inside the core and in the perilesional space. We also find that focused ultrasound is enhancing the total amount of small molecules and biologic size molecules to CCMs. And then I didn't have time to show this data due to time, but we also see that focused ultrasound really helps the delivery of small molecules into the perilesional space, more so than the inside space, even though it is increasing both. Whereas with biologic model drugs, we actually see that there's a better effect in the inside of the CCM core rather than the perilesional space. And so looking forward, we of course want to move this preclinical stage all the way down to clinical trials and hopefully regulatory approvals. And so just to give us a little glimpse into what that might look like, fortunately at UVA, we've actually been able to see what clinical treatment of CCM with focused ultrasound might look like, thanks to Dr. Jason Sheehan and David Schlesinger. They were able to basically reimagine treatment plans for CCM patients that had previously received radiosurgery. And so here I'm just giving you an example of one patient, but these patients received radiosurgery because they were not candidates for conventional surgical resection. And about 11% of these patients received radiosurgery and experienced adverse radiation effects. So using the NaviFus clinical system, Dr. David Moore designed focused ultrasound blood-brain barrier opening treatment plans for these same patients. And you can see that the CCMs are actually accessible. These are basically the focused ultrasound spots that would be placed on these CCMs. And we find that these lesions were all accessible with this NaviFus system. So ultimately, this is telling us that the technology is really ready for these treatments, and hopefully in just a short period of time, we'll also have the science there too to start moving these into clinical trials. And so some future directions to help us enable getting that science to that point, we would really like to understand how this is therapeutically working, how focused ultrasound actually helps CCMs. So we would like to look at how the cellular response is changing following focused ultrasound in these lesions and how mechanical stimulations might contribute to this therapeutic benefit. We also want to evaluate the therapeutic potential of focused ultrasound in more models of CCM. So this model that we used today was a mouse model of the CCM1 or CRIT1 mutation. It's also the familial form. So we'd like to look at other familial mutations as well as sporadic versions of the disease, as well as looking at CCMs in other central nervous system locations. So in the spinal cord as well would also be really nice to look at. I'm expanding this quantitative MRI technique for focused ultrasound would also let us allow or assess the drug retention at later time points, as well as to measure the delivery of even larger size molecules and their ability to be enhanced with focused ultrasound. And so finally, before I turn over for questions, I just want to really acknowledge all the people that have made this work possible. So I want to acknowledge the Price Lab at UVA, especially my mentor, Richard Price. I also want to mention all the students that have helped to make this work possible within our lab, as well as Tanya Cruz, who is continuing this work now that I have graduated from UVA. She's going to continue doing these focused ultrasound approaches and also doing some computational modeling as well. I also want to mention Peter Tverdict and Khadija Sharifi and acknowledge their work in creating our mouse model and giving us a lot of expertise for CCM, as well as Wilson Miller, who helped to optimize all of our MRI approaches for these projects. And then finally, of course, none of this would be possible without funding. So I want to acknowledge all of our funding sources. And then finally, I just want to put in a plug for the Focus Ultrasound Foundation. If you would like to learn even more about Focus Ultrasound, either for CCM or beyond, they have a really great website called fusfoundation.org. You can find a lot of really good information there for patients, researchers, clinicians, everywhere in between. So I recommend checking that out. And with that, I think we can turn it over for questions now.
Thank you so much, Delaney. So if you want to stop screen sharing, that'd be amazing. Thank you. So, I mean, what an informative presentation and just so exciting to have the potential of this. And I think something we have here, which we don't have in the same way with a lot of other new treatments in development, is this is already being used for other conditions. So in terms of the safety, we've got such a wealth of evidence, which gives a real advantage to this research, doesn't it, in terms of the speed at which we might be able to progress this, which is exciting.
Yes, exactly. It's really been a mission of the Focus Ultrasound Foundation to really, if we help with any disease, we help with all diseases in this case. So it's great.
So we've had a few questions, and if you've got a question you haven't yet popped it in the Q&A, please do. We love to get your questions. So I'll just take them in order from the beginning. Somebody said, I've got a brain cavernoma. It's in my left frontal lobe, and the neurologist has suggested surgery. And they've got a question about MRIs. So they've been having MRIs for 5 years. They had one 6 months ago. And they say they're concerned it may have resulted in facial twitches. That feels like a jet force when I have my daily partial seizures. And I think they're wondering, given your knowledge of focused ultrasound, your understanding of the extent to which could an MRI potentially be causing that?
So I just want to preface, I am not a medical doctor, so obviously I can't give medical advice in this case, or any case. But MRIs are really non-ionizing radiation. So as opposed to something like a CT scan, you might see more effects with more exposure. With an MRI, you typically don't have any side effects. Of course, if you are uncomfortable in an MRI, that can cause physiological effects, but there typically, to my knowledge, has not really been effects caused by MRI. It's really quite a non-invasive approach. But I would definitely recommend just seeking out medical advice from your doctor. They will know more than I do about this. So.
Absolutely, and I think that's a good point there. You know, we always say if you have a substantive change in symptoms, do go back to your clinician. Sometimes there may be something, and it's coincidental that the two have happened at the same time, and actually there could be something else going on. So that's always important. The next question, and Delaney, I'm conscious this is, early stage research, so you may not be able to answer that. But we have a question about if you were, for example, to have focused ultrasound as a treatment, what would happen if you had a bleed or seizure during the treatment itself?
Yeah, so the mouse models that we're using, we know that they bleed, their hemorrhages or their CCMs are bleeding as well. We didn't necessarily screen the mice to choose cavernomas that were or were not bleeding, and we treated a large number of cavernomas during these studies. So I believe we've definitely treated lesions that were bleeding, and we didn't robustly check to see if the bleed or not bleeding had any effect with focused ultrasound or effect on the ability of focused ultrasound to help stabilize those lesions. But I believe that we didn't see any catastrophic effects from this. So I would say that it's likely still going to be safe, even if these lesions are bleeding. Obviously, I think it's better to probably wait until the lesion has stopped bleeding to do that treatment. I think that's probably just a better approach. But it seems to still be safe. It doesn't seem to lead to any bad effects that we could really dramatically see. As far as seizures go, so with focused ultrasound, the patient's head should be stabilized. We wouldn't want the patient's head to be moving while focused ultrasound treatment is happening, and that would be potentially a problem with seizure. However, with blood-brain barrier opening, we know that this is really a safe thing to happen. So patients have, with many different diseases or not having diseases, have had blood-brain barrier approach happen, and we don't see any negative effects from that. We actually tend to see positive effects from that, which is why we're pursuing it. So I think even if a head was moved during this treatment, ideally that would not be the case, but it doesn't seem like that would actually be causing a problem if we treated the slightly wrong part of the brain that we wanted. But that being said, we have ways to pretty much there are different clinical systems. So some basically are free forms. So you have the focused ultrasound transducer, which is what produces that sound wave separately from the head. But we also have ones that are actually pretty well connected to the head and is stabilized. So that might be a consideration if you are prone to having seizures with your CCMs, is what clinical system is used for every individual patient and their history.
And it's good to know that there's different delivery mechanisms and there's potential option to give consideration to that, given if someone is regularly having seizures. And so another question, this relates to people who are having Cavernoma-related seizures, and that's about anti-seizure medication, and could that potentially be contraindicative with focused ultrasound?
To my knowledge, it is not. However, I'm not necessarily up to date on that. So I would, again, defer to what medical experts would say for this. I believe the focused ultrasound is also being pursued separately as a treatment method for seizures. It's likely different than what we're using here. It's probably not blood-brain barrier opening as that approach, but that lends me to believe that probably anti-seizure medication is not a confounding variable for using focused ultrasound.
I think this is a really interesting aspect about focused ultrasound, is because it's been explored amongst so many different conditions, we're really benefiting from that. And, I think that's a real, opportunity here. So next question, there's lots of questions for you, Jane. There's a lot of interest in the chat on this. So this question is, in your first series of experiments, one research question is FUS, BBB opening, so opening the blood barrier, safe for hemorrhage-prone CCMs. How do you know that the white contrast you saw on MRI, which you interpreted as GD crossing the BBB, was indeed GD and not hemosiderin from a leaking lesion?
Yes, so that's a great question. So we, in all of these cases, take a pre-focused ultrasound image where we've already injected the gadolinium into those mice. So we basically have the baseline of what those mice look like, both 2 days before we actually treat, so that we can choose our lesions that we're going to target, but we also take it immediately before focused ultrasound. So assuming that there is no change within the 2 minutes of somnification other than the blood-brain barrier opening approach that we're applying, we can really differentiate what the baseline is for that individual cavernoma compared to what we induce with focused ultrasound. So that's a big part of the control for these experiments, is that we're always treating those same cavernomas and we have the baseline for that cavernoma right before we treat.
Excellent. Thank you, Delaney. So the person who asked a question before about MRI, they're really interested to know, is a focused ultrasound like an MRI? So maybe if you could just recap again how a focused ultrasound differs to an MRI in terms of its mechanism.
Yeah, of course. So MRI is this imaging modality, and you all have probably have a lot of experience with MRI. So, you go in, there's this big magnet that basically is able to capture an image of the brain. Focused ultrasound is different because it's this ultrasound wave. So it's actually it's a lot more quiet than an MRI. You don't really hear any sounds involved with it, despite it being a sound wave. It's something you can't hear. So in this case, we're using sound waves rather than magnets to cause an effect. So basically, we use MRI with focused ultrasound. It allows us to visualize where we would like to treat and visualize the result of the treatment, but it's very separate from the MRI itself. But we do pair it together most of the time because it lets us get really accurate information about where we want to treat when we're treating within the brain or the spinal cord. So we use MRI as the tool that lets us enable the targeting with the focused ultrasound, but the focused ultrasound itself is quite different from the MRI.
Lovely, thank you. So next question. Somebody's saying, isn't the blood-brain barrier already open in cavernoma because of their leakiness? Why does it need even more opening?
Yeah, this is a very good question, and it does come up a lot. And I think it's really important to understand. So the blood-brain barrier and its leakiness is more of a spectrum than it is a binary. So I think we frequently kind of tend to think of things as like a yes or no. Is it open? Is it not? But really, it's more of this binary situation. Spectrum situation. So with the cavernoma, you tend to have a slightly leaky blood-brain barrier. There's this chronic leaking of blood, but it's not very open. And we could see that with our pre-focused ultrasound images where we injected the MRI contrast agent. But again, that was before focused ultrasound, and we could just see little specks of the gadolinium or the MRI contrast agent getting around that CCM. Following focused ultrasound, we see lots more of that MRI contrast agent getting in, indicating that we're much further down on that spectrum of blood-brain barrier opening. So when we think about this therapeutically with drug delivery, we can see that we're really not getting a lot of drug in, despite the fact that the barrier is a little bit open. And if we could actually open that more, we can get more drug into that specific spot. So that's kind of the goal. Can we just open it a little bit more so that we get more drug in? We're only going to do that for just a little bit of time while we inject that drug so that we get the drug in, but then it'll go back to its baseline and that we still have a very safe approach. So that's kind of the idea there.
Lovely. So Delaney, we've come to the end of our questions, and I just want to say thank you not only for a very informative presentation, but also taking the time to explain it in a way that we can all understand and putting it into terms that are easily accessible. That's a real skill, and we really appreciate you doing that today.